We know that Mount Sinai Hospital is one of the most famous hospitals in cardiovascular field in US and in global. And Professor Tang have lots of contributions and also well known in global. And also today we also have the Professor Samin Sharma together with us. Now I can have Professor Tang to moderate the first case from our center.
Thank you very much for the invitation. Hello, everyone. On behalf of Dr. Sharma, who will join shortly, and myself, we welcome this collaboration. 你们好，谢谢你们的邀请。OK，现在我们做一个第一个Professor Mao Chen 的 case. Please go ahead. 谢谢。
Yeah, we will ask the Dr. Zhao have the introduce of the case. This case is done was done today morning in China. In our center. So I think this is very challenging case to us. So we have so many questions want to discuss with Professor Sharma and Professor Tang. Okay, go ahead, Dr. Zhao. 小赵，你没有打开静音，你没有打开静音。
Good evening to our Chinese colleagues and experts, and good morning to Dr. Tang and Dr. Sharma. So I will present the case on behalf of the team. And the patient is a 72-year-old male, and he presented with progressively worsened exertional dyspnea, a cough and sputum for 7 years history, and he has COPD, and at this time he had acute decompensation of chronic heart failure and cardiogenic shock. He had PCI 8 years ago, but at the current hospitalization, coronary angiogram demonstrated no significant abnormality, and there is no restenosis in the prior stent. And the treatment currently include antibiotics, and he was intubated shortly after admission. And the medications include vasoconstrictors, diuretics, and SGLT2. And this is the EKG of this patient, which showed sinus rhythm and LBBB morphology of the QRS. And it is interesting in this patient in terms of the severity of mitral regurgitation was dynamic. On admission, it was at the end of September. The echo graded the mitral regurgitation as 3 to 4 plus, but shortly after this, the patient's condition get worsened, and he was intubated. And after intubation, the echocardiographer evaluated the mitral regurgitation. It decreased to 1 plus to mild, and this remained after the intubation. And on October the 8th, our echocardiographer re-evaluated the severity of mitral regurgitation. It was still 1 to 2 plus. And we have some parameters, including LV and diastolic diameter of 72 millimeters, small left atrium, which was 28 millimeters, and LVEF was only 27%. And after medical treatment for this patient, his condition got better, and he was extubated after October the 8th. I think the date here is running spell. But after the extubation, the mitral regurgitation was 3 plus, and VC was 7 millimeters. And the patient's condition also get worsened, which was in line with the worsening of the mitral regurgitation. And at this time, the LA diameter, which was remeasured at 35 by 51 millimeters, and LVEF was still around 30%. And because the baseline echo was performed at another hospital, so we do not have the original images, and the recorded images showed us that this patient had really severe mitral regurgitation before the intubation, and there was significant enlargement of the left ventricle and relatively small left and right atrium. And as we have just mentioned, after intubation, this patient's mitral regurgitation was reduced to mild, and this was confirmed by an re-evaluation several days afterwards. On October the 8th, the echo also showed only mild to moderate mitral regurgitation. But we can also note that at this time, the left atrium was even smaller than at baseline. And these images are also obtained when the patient was under intubation. And indeed, the mitral regurgitation was not severe. However, after the extubation, we can see that the mitral regurgitation get worsened to moderate to severe again, and along with the worsening of the patient's clinical condition. And these images are also obtained after extubation. So it's 3 to 4 plus mitral regurgitation. So the heart team considered this patient's condition was highly related to the dynamic mitral regurgitation in this patient. So I think our echocardiographer, Dr. Liang, has some further images which was obtained today, just shortly before the procedure, and she will present those images to the experts and audiences.
好的，那我来 share 我的屏幕。Okay, dear colleagues and experts, let me show you the TTE performed just before the procedure. And at that time, the patient was not incubated. And the TE images show, oh, I'm sorry. This is not the first one. These TTE images are got before the patient was incubated. So we can see here that the patient's the patient has a very large left ventricle and mildly dilated left atrium. And we can see that the LV systolic function is severely impaired with ejection fraction around 20%. And there is mild pericardial effusion. And from these images, we can see that here, the mitral regurgitation is moderate to severe. And during that time, we noticed that there is a relationship between the patient's respiration and the MR severity. During expiration, we noticed that after the patient was incubated, we performed the TEE echo for the patient. And also, we can see a very large left ventricle with impaired systolic function. And the MR severity was improved. TTE image just before the incubation. And there is no morphological abnormality was observed in the mitral valve leaflet, but we can see that the posterior leaflet was tethered and was restricted during systole. So there is more coaptation of the anterior and posterior mitral leaflet. The MR severity seems to be moderate during this time. And we also observed the interatrium septum and the length between the mitral annulus and the roof of the left atrium is only 32 millimeter. That's a very short IAS. So in summary, for this patient, we think that the MR severity, MR etiology is the secondary MR, and it's Carpentier type 3B. The MR severity varies from 1+ to 4+, so it's a dynamic MR. And the mitral valve area is 5.22 centimeters square, while the mean transmitral gradient is 5. And the leaflet length at the A3 and P3 region is 27 and 11 millimeter respectively. That's all.
Okay.
Thank you.
So I think this patient is very interesting. And hi, Professor Sharma.
Yes, I'm sorry for a little late here, but I am following this very interesting case, very dynamic, very sick patient, but looks like going into the right direction now after intubation.
Sure. So I think this the first question, because the patients have the two, to me, I think the two possible options of the intervention procedure. The first is just because the dynamic mitral regurgitation, and so the TEER is possible therapy to this patient, and also the patient has the wide QRS LBBB morphology shape, so and combined with the reduced injection fraction, so maybe CRTD is another optional choice. But just because the situation of the patient is so worse, so my first question do you think this kind of patients we should do TEER for these patients just because the dynamic, the motion, model, this style of the dynamic mitral regurgitation? How about your idea? Will you do the TEER for these patients or not?
Yeah. So I think maybe Gilbert can also comment. We have some few cases of like that in last few years, and there have been data now that fulminant heart failure, cardiogenic shock, and the patient was on balloon pump. Actually, our patient was even balloon pump. We did and same, so dynamic. MR is so dynamic, and did the clip, and patient did very well. Gilbert, you want to comment?
Yeah, no, thank you. It's a very complex case that you outlined here. You know, the goal of these TEER cases are to bridge to decision and recovery. That's the goal, to get the patient to survive the hospitalization. Because even though they can be surgical candidates, you know, you want to kind of bail them out. So in your case, the patient is intubated. Obviously, we need to get them extubated and go home. In our case, as Dr. Sharma mentioned, patients on a mechanical support. We need to wean the mechanical support, and we discussed our surgical colleagues all together as a heart team and said this is the best and safest way to reduce the MR. And then afterwards, you can then decide whether to do CRTD, you know, GDMT and other things. But the first is to save the patient's life. That's the goal.
So I think our choice is right, as you have said. Maybe this is save life of these patients, but the another really challenging to these patients is the technique scale, because you can find the symptom is very short because the left atrium and the right atrium are very small, and even we have the saline resuscitation, the height about 3 centimeters, just 3 centimeters. So I think this is another difficult to these patients is technique, difficulty. So just because we think these patients no other choice, so we want to try in this morning in our center. So I think Professor Dr. Zhao can show us the recording case.
Okay, so these are the recordings of the procedure which just occurred this morning. And Dr. Feng is currently doing atrial septal puncture. And actually, the echocardiography has already measured the height, and it was only 25 millimeters.
Yeah, we want to puncture higher, but it's final. So finally, we just have the puncture height, only 2.5 centimeter. But the regurgitation looked in the close to the 3 zone. So to some extent, I think it's very challenging. That's all. Go ahead.
So then Dr. Chen started to insert the CDS. I think any comments are welcome when we are replaying the recordings. And if you think, okay.
Yeah, no. So what clip did you decide to use?
In China, we just the Arbot XTR and NTR, no G4. So to these patients, we're using the XTR.
XTR, this one?
Yeah. Just
Yeah, I
because
agree
you
with
know,
XTR. I think the challenge that you mentioned is the transeptal height. So
Mhm.
I think if you plan to do XTR here, we would in our center we would do advanced steering right away. So we would not just do the M knob and posterior guide torque because you know that you will not have enough height. You would do the the advanced steering with the P or A knob steer.
yeah, yeah. So I think the key point is how to get at the P3 and the S3, and so like you have mentioned, we should balance the CDS and the vertices and steering sleeve, and to maybe we should borrow some kind of height, just using the volume, the the left tribe. I asked to Professor to one question. In your center, we always see the central height is so low. Maybe this patients we can call maybe the red patients are yellow patients. That means the TEER is not very good for these patients. And in your center, do you think the puncture height is the mandatory indication for TEER to these patients?
Yeah, no, it's a very challenging situation because if you don't get enough height, you will not be able to do the procedure. So yeah, no, I mean this by default is not a green case because patient is in shock. You have a small atrium, it's most likely more QM dynamic MR as you mentioned. So by default, it's already a complex case. Even though the grasping anatomy is not that difficult in terms of leaflet length, and you have excellent imaging. I think it's very low risk, very safe to try. And sometimes we try even, for example, in patients with small valve area, right, or higher gradient, like so with mitral annular calcification, or MAC. So sometimes we tell the patient that we may not be able to deploy the clip if the gradient is too high, even though we have a good MR reduction. But because MitraClip is such a safe procedure, I think it's very reasonable if the patient has no other options to consider that.
Yeah.
So it looks like you're already on the valve. You already done the 3D steering.
Yeah. To these patients, we make the decision to try the TEER. That's because the patients is the etiology of the mitral regurgitation is a functional mitral regurgitation, not the degenerative mitral regurgitation. If it's a patient's prolapse mitral valve, I think it cannot do because it's very difficult to grasp.
Yeah, so it's nice to see that despite you have, you know, well below even 3 centimeters of height, you're able to steer with advanced steering, which I noticed you did, to get to the medial aspect of the valve without, you know, with actually still some height left, and still actually very nice trajectory to the pathology, because you don't have an aorta hugger, you know, which would make it even more challenging if that happens. So very nicely done. You can see that here. You can actually now you know, check the orientation, and then, you know, go ahead and see where the jet is and grasp and go into the ventricle. Very nice. And like your procedure here was very important to show fluoroscopy. We use a lot of fluoroscopy as well for our procedure to make it more efficient. And we published this before, and we put this into the Sky MitraClip ebook to show the orientation of the clip. You can use fluoro to make sure you do not spin or rotate when you go into the ventricle, which can happen, especially in a dynamic situation. So
I think this is tricks and tips is personal to us because we are familiar with the DSA imaging, so can help us to make sure the, you know, the trajectory in the same orientation.
And correct, and you can also see that you did not have a medial or lateral dive, because you have the fluoroscopic lead bar to check as well, in addition to echo. So it's a nice complementary way. And at our center, our imager can also see the fluoro as well, so they can see where the probe position is and also the clip position, so we can work on a procedure really quickly.
So when we do the what to do the clasp to these patients, we meet some difficulty just because they cordy, you know, like the. But I think that not this the position is good, so we will move.
Yeah, the difficulty with these cases, as you know, is the heart rate. You need to have a slow heart rate to grasp more easily, but these patients are in shock, they are sick, so the anesthesia colleague cannot reduce the heart rate for you to grasp, because otherwise the patient may crash. So it's very
maybe we just we just try to control the, you know, the volume and the rhythm of the breath, just to make the
Yes, that's right. So yeah, absolutely correct. That's a great teaching point, that you can drop the tidal volume. You can also, you know, stop the breathing for a moment to do the grasp. You know, worst case scenario, you can see we can give a little bit of short acting beta blocker just for the grasping, but without G4, this is an extremely challenging case.
Yeah. So like this patients, just because the tensor of the posterior leaflets, it's to some extent, I think it's difficult to hold the leaflets into the arm and grasp the clip. A little bit difficult. So I always hope we can have the G4, because the independent grasp can help us very much. And but in your sense, when you use the G4, you will, how many patients you will using the independent grasp?
So number one, I think we use it to optimize more than independent grasping. But in a very big flail or gaps between the anterior and posterior leaflet, let's say in secondary MR, we would often get the anterior leaflet first, and then bring the clip delivery system further into the ventricle, and then close the clip a little bit, and then hook the posterior leaflet to grasp the posterior leaflet, because they're often shorter. And so you want to grasp the entire leaflet, including almost to the annulus. So that's, we have done that as well, but we try not to do the independent grasping, because with the motion of the heart and the respiration, you can end up grasping the wrong spot on the opposite side. And then you can twist the valve and have a jet. So we try to do no independent simultaneous grasping whenever we can. Only if we cannot, or we need to optimize. But when we do optimize, we do it we do the posterior guide top first, raise the and then bring the clip up to make sure the leaflets is good and better, and then raise the grippers and drop it again quickly. So we don't wait a long time for the heart to have that motion to shift your coaptation. If independent grasping, the same thing, we would get ready for the first grasp for the anterior leaflet usually. Then we drop the gripper and quickly go to the opposite side, again, to avoid this shift in respiratory motion and also the heart motion because of the corkscrew.
Yeah, it's very important teaching point.
Yeah, so very nice here. You can see the leaflets are on, anterior leaflets on. So typically what we would do is you can close the clip a little bit, and then you can then hook the posterior leaflet. Sometimes we even use an intentional aorta hugger. So what that means is that because the posterior leaflet is short, so we'd actually go a minus knot to create almost like an aorta hugger, so that you can what we call hook the posterior leaflet more easily. Especially with G3, because G3 you cannot independently grasp, so you need to make sure both leaflets are inserted before you can drop the grippers, and that is a potential nice way to handle this kind of difficult situation.
Yeah, in that to this particular patients where we do the intentional hugging, and to make sure the potent leaflets can be grasped very good.小赵，我觉得可以快一点啊，因为这个像就是到后面，因为这个主要是这中间的过程。
I think the engineer is currently controlling the speed. I will ask him to speed it up.
Okay. But to this particular case, I think it's challenging to hold the posterior leaflets into the M, because it's a little bit of curve. So
you're right. So you need to make sure that you don't curl. So here, what we would typically do is to close the clip a little bit to cup it.
Yeah.
So you close the clip and then you bring the clip up slowly, so the anterior leaflet stays on, and then you keep the posterior leaflet not curl as you mentioned. I think the clip orientation is good already. So again, because of the time, we try to not take too long to grasp these anatomy. We try to go in, like you said, close the clip a little bit, then pull up slowly, because the heart rate is very fast. So you can actually rotate the clip. It's actually not that easy to handle this situation, and then you just try to get a grasp as quickly as possible. If you need to optimize, so we have learned to use G3 that if you need to optimize, you can always, once you grab, you can stay the grippers down, open the clip a little bit, and then you can do the rotation and then raise both grippers and drop again. So that's a small trick that we learned with G3, which we have adopted with G4. But certainly it's doable. But you have to position your clip optimally to raise before you raise the grippers and drop again if you want to optimize your grasp without losing the opposite leaflet. Yeah, so now as you can see, it's very nice. You can see you closing the clip, right? You close the clip a bit, it cups it, and it kind of prevents the leaflet from falling out. And now your posterior leaflet, both leaflets are on, then you can now, yeah. So now I would, drop the grippers here.
We just want to make sure the position, the orientation is good. We do the grasp because we don't want to injure the leaflets.
Yeah. And also remember, this is a rescue case. So even if you go down to 5+ to 2+, it's okay. The patient will live. So you don't have to be perfect. And you only have G3. So you want to just grasp safely, good insertion to avoid SLDA, and do your check tissue bridge gradient. You can even check pulmonary vein flow. We actually, even with G3, we published this paper before. You can connect the the flush port, to the pressure tracing. You can actually do that. You don't need G4 to do that. It's not as good. Sometimes it's dampened, but it's still possible. So sometimes when we publish this paper, we have used it to even diagnose mitral stenosis. So for example, if you reduce the MR, but your V wave went up, that means you have stenosis. You cannot deploy the clip. But even if the gradient may be a little high, if you reduce the MR, the V wave you maintain and it's lower, that means you can deploy the clip safely because hemodynamically you reduce the LA pressure. So it's actually a very nice way to determine decision making whether you can deploy the clip or not. And so we've done that. We published that already. So it's even with G3 you have that ability. So I would encourage you to consider that in the future as well.
So after the clasp of the clip and the regurgitation reduced to maybe mild or trace. So I think the result from the regurgitation volume is okay, but we do the immersion gradient like you have said. But the gradient, the chest mitral gradients, maybe the mean gradient 8 millimeter mercury. So we do the measurement of the two parts of the orifice, and I think the total size of the orifice about 2.5. So even the choice mitral gradient is a little bit high. We do the final decision to release the clip.
Remember, your heart rate is fast, right? You are in a very dynamic state. So I would not really care about the gradient. And even though, the patient is only 72, if you have to do surgery later, you can still do surgery as an option, let's say with stenosis. You just want to get the patient out of shock and MR, and then you can manage the rest medically. So I would not really believe in this gradient. You can always, after now, the patient is extubated, then you can have guideline-directed medical therapy. You can even consider, as you mentioned, CLTD to further, better synchronize the heart to reduce the heart rate. So you have a lot more options to manage this patient after you get this initial problem.
Yeah.
So really nice
totally
result.
agree with you.
Very nice result.
Yeah.
The key is going to be
Wait,
diurese this patient aggressively to make sure the patient doesn't, have a heart that stretch and dilate. So have to be very aggressively make sure the patient is volume negative. So, but great case.
Yeah. Thank you.
Fantastic case. And hopefully, and we wish the patient recover well.
Yeah, we hope so.
Now, let me ask you, did you think about balloon pump also or no? For acute
blue
situation,
pumping?
yeah, intra-aortic balloon pump. I know a couple of cases in this situation we have done the balloon pump, but I just wanted to hear from your point.
Just after the TEER, I think the blood pressure a little bit better. So and recover very quickly. So we don't use the balloon pumping to this particular patient.
Okay. All right, but very good. Listen, very tough, complex case, superb. I know many times to show it live, that was originally plan was, would have been a little truncated, with a time point of view, but you took your time and did a beautiful case. Gilbert, you put a last word and then we conclude and then we'll be ready for our case in next 10 minutes.
Yeah, I think you're going to be very happy with the G4 system once you have it. We had it for more than a year now, and this is an extremely challenging case. So congratulations for excellent imaging, excellent work, advanced steering, and in this complex situation. So best wishes on the patient, and I think the patient will do very well.
Beautiful.
Yeah, 恭喜你们啊！
谢谢。
Okay, we'll see you soon. I'm going to get ready for our portion of the case, okay?
Okay.
Good morning and welcome from all around the world to Structural Heart Live Cases, broadcasting directly from the Mount Sinai Hospital in New York City. My name is Pedro Moreno. I'm an interventional cardiologist and I will be your moderator today. We would love to welcome our Chinese moderators for this case, Professor Cheng Mao and Professor Feng Yang. We'd love to hear from you, so please send us your questions right from the website or from YouTube. Remember, you can view all our previous structural live cases at ccclivecases.org. We have a great case today, so let me take you to the cath lab at Mount Sinai Hospital for the live case.
All right. Good morning, Pedro and our Chinese colleagues. They showed actually very interesting high-risk case of TEER. A patient was in almost shock, intubated, and so. And hopefully we'll kind of duplicate same excellent results which they got. And of course, viewer our CCC live structural cases. And today, on a strong demand, we have shown various kinds of tower, and now we are going to show the mitral clip, basically TEER, in this particular patient. And the faculty here with me, Dr. Keeney on my left side, Dr. Gilbert Tang is our surgical director, structural director, and Dr. Sahil Khera is our structural director interventionalist at Sinai. And then we have two fellows, Rajiv and Supawat. So they all do a lot of work, and of course rest of the staff inside. On the echo is the Dr. Larakas, and on anesthesia is Dr. Jill. With that note, we are all set, and of course many faces familiar you'll see, and we start our presentation. Interesting case in the sense I made all, and I just put Dr. Chen Mao, but I know the additional faculty. And with that note, case today is M-TEER in high-risk patient with primary MR, secondary to Flail and Prolapse P2. This is the patient with a case number of 55. Patient is 61-year-old, dyspnea, and has a disability to walk. And lastly, because of polio or some some issues
Morbid
had been
obesity.
also Jehovah's Witness. Jehovah's Witness means for those who do not know, that patient cannot get blood transfusion, and multiple risk factors are shown there. Good medical therapy, and patient has been on intolerant to few of them, and had a severe anteriorly directed mitral regurgitation from the Flail and Prolapse P2 with ERO of 0.4 millimeter square and EF of more than 55% and mild LV enlargement and mild TR. So with that, this is the crux of the case. Basically, severely directed anterior-directed mitral regurgitation, which is recorded, and we actually can show even the current one. This is a trans-esophageal. You can see, and we can ask our expert comments from our echocardiographer, Stam Laracus.
Yes,
this is the mid-esophageal view.
Yes, good morning. Good morning from New York. I have with me our imaging fellow, Julia, and also our sonographer, Hafiz. So, well, we're real life. Yeah. So basically, 4-chamber view, normal LV function, normal RV function. You can see here, this is long axis view of the mitral valve. You can appreciate the Flail posterior mitral leaflet. This is the measurements of the leaflets. The anterior leaflet is 2.2 and the posterior leaflet is 1.4. This is the centric anterior jet from the Flail posterior leaflet, P2 scallop. This is a 3D image. Okay. You can see the aorta in the top, the posterior leaflet in the back, and the Flail leaflet, the Flail P2 scallop. Significant broad jet of mitral regurgitation. This is the true view. You can appreciate the Flail P2 scallop. This is the glass image where you can see the Flail P2 scallop even better, and the white jet of mitral regurgitation. The ERO by 3D is 0.52, severe, no doubt severe mitral regurgitation. The area of the valve is 6.5 centimeters square, good for MitraClip 1 or 2 clips, as will be discussed. The gradient is 2 millimeters mercury. The pulmonary veins, this is the left upper pulmonary vein, is blended, systolic blended. You can see the appendage in the middle, clean appendage. And this is the right upper pulmonary vein, again blended, systolic blending of the flow. And this is a deep gastric view showing no pericardial effusion to start with. Thank you very much.
Beautiful. So this is live shown, and we go back to the slides. And I just want to emphasize once again on the points. These all have you shown, and more we show it while the procedure being done, and 3D images on this particular case, ERO and leaflet lengthwise. Any concern, Anu and Gilbert, in terms of leaflet length to grasp? Posterior leaflet is 10, anterior leaflet length is about 26 millimeter.
There should be no concern. Actually, should be easier to.
Yeah, I think this will be an ideal case for a XTW. The question is that is it a 1-clip, 2-clip strategy that you saw earlier? I think it's a big valve, broad prolapse. I think right now the strategy is going to be 2 clips to also to stabilize the repair. 1 XTW to start and then a 1 XT to follow. That's our strategy.
And Sahil, you want to comment on the transeptal, this technique of the safe cross?
Sure. Yeah. No, Dr. Kinney is going to discuss step by step how to do the safe cross. It's basically a balloon-tipped catheter making transeptal really safe. Instead of a needle or a dilator-directed catheter, you have a balloon on top, just like a Swan-Ganz, engages the septum, and then you can cross through it. Very reproducible, very safe. So we really like this device.
Beautiful. Okay. So now comment on the MitraClip G4, which is available here, and we know that our Chinese colleagues said G4 is not available in China. So in this particular case, that is the plan to.
Yeah, so G4, as you see, has 4 different sizes and lengths as well. So basically, there's 2 different widths. W is the wider portion, but if you look at it, the picture, the wider portion is actually at the leaflet area, not up in the top. So that's a little bit a unique design. And then the length, obviously, we know they have two different lengths here. So our strategy at Mount Sinai has usually, if the leaflet is long enough and you're not going to pucker the valve, then we typically use the longer clip. And we'd like to use the longer and wider clip to start, or the end. So the W is our workhorse clip, and you can see, I'm sure Dr. Sharma might show that later on, the Expand G4 data, that's also been the case.
Very good. So therefore, this patient is, clearly with the degenerative mitral regurg is only done patients who are high risk, not necessarily inoperable, which used to be in the past, but high risk. And this patient is high risk because Jehovah's Witness, from the blood transfusion he cannot take, patient cannot take, she cannot take, and second is obesity. So both those factors, we have a heart team discussion, and they felt that if we can do a good job of reducing mitral regurgitation to 1+ or less, we should go ahead. And there was a discussion with our echocardiographer, and all the interventionists happened, and they were very confident that we'll be able to do a successful TEER procedure with a very small residual mitral regurgitation, and that is why this patient is on the table. Now, we know that Jehovah's Witness, they can sometimes get the surgery also, although many centers are notable to do the Jehovah's Witness surgery. Sinai is one of them, and basically require giving the epocret, epogens, and quite a bit to bring the hemoglobin to more than 13. Sometimes it's very difficult, but because of some knowing that if there is an alternate solution and can be done safely, and that is what we decided in this particular case to go for TEER, despite the severe primary MR and the low risk of STS. This is not because of the high STS risk, it's just because of the clinical condition of the patient. I think obesity still could have been, but the Jehovah's Witness is a very big factor. With that note, we are ready to show, Anu, your show now. Tell us what the plan and what you are going to do.
So here we have the safe cross that we are going to use to do the transeptal, if you can focus, right? This is just to flush the central lumen, and some dye that will be ready for the balloon, small balloon that is at the tip. This will be the connection to the energy, which is the RF energy. The wire is already there. So just simple movements, if you see here. So this is to a little bit, flexion, which is we can to get into the septum. But more important, I think, we have to do is when you are going there, you will go clock to get into the posterior, or this would be to any kind of anterior movements. So right now what we'll do is inflate, right? Go up, the deflated one will go up there. Good. You'll see.
Explain, please. Explain.
All the way. This is exactly like you use with any other wire. The typical steps where you have to go all the way to SVC and come down. We don't have to do all those steps.
Okay, follow, please follow.
And we will see in the fluoro, injecting some dye, just a little bit. Yes.
That's good.
Balloon flotation. So we will do is take out the wire, and then we will have our
the needle, please. Let's focus.
The workhorse stiff wire, which is a safari.
Safari wire. We're going to go with the safari wire and have it ready, that once we get the transeptal, we'll just advance the safari into the left atrium. All the way. Okay, just leave it there. So I'm going to just get into the septum with a little flex. That's it. And just like any other movement, right, I will go posterior.
Full, please, full.
So can we show echo, please?
Clock,
Live echo.
I'm clocking to go.
Yeah, please show echo and as well, and on and fluoral. Free. We need free screen, please.
We see that. Maybe I put a little bit more flex. No.
I will just go.
Pull down. Come down a little bit. I'm coming down.
That's it.
I think it looks good.
Stem.
Yes.
You can see that radiographic balloon there, very visible on echocardiography.
It's not showing the whole thing.
Now, Professor Chen and Dr. Fang, is the safe cross available in China yet?
No.
They said
Not yet.
Not yet. Okay.
Okay, put X-ray, please.
Okay, it looks good there, Gilbert.
A little posterior.
More posterior?
Yeah. Your mid.
I was posterior, then I came little anterior. So I'm clocking more to go posterior.
Mm-hmm. Yeah.
Micro movements.
Very good, very good, very nice.
Okay. Right there.
Fluoro. So that's the only time we take the dilator out once you've reached your destination.
Should we give the energy here?
No, let's measure.
You
A
know,
little superior.
I think we are good.
So what we do typically, just for the people who are not familiar with TEER, the next view, as you see here, is the aortic valve short axis to see how posterior we are relative to the tenting.
can you explain that, please?
So we need to look at that, and we usually do explain now. So we can see that it's not quite tenting; it's a little bit skiving there. I think you can see.
Not tenting, yeah.
Yeah. So maybe we need to adjust that a little bit. Go back to the bicaval, I think.
Okay. Explain, please. Explain.
So come down a little bit.
Yeah.
Come down.
Follow that. Follow.
Yes, it's quite
More posterior
It's
now.
quite posterior, and I
No.
think it's also superior.
Okay, now.
Yeah. A little bit more inferior. A little bit more inferior.
Inferior now?
Yes,
Yeah.
please. Yeah.
Okay, there.
No. A little bit more.
I think we were in a very good position earlier. No?
There you
Good.
go.
So you see that, right?
That's better.
I think that's better,
Just
yeah.
a bit
I
more
think that's better.
posterior.
A little bit more posterior now. Yeah.
You go more posterior?
So you're mid and mid.
Yeah.
Just go a little posterior.
I think
Okay.
Yeah,
should be okay there.
a little bit more maybe.
Little bit more. Little bit.
Yeah, that's
Good,
perfect.
Good.
Oh,
Stay there.
So again.
Let's go out with the
Superior
dilator
again,
pressure.
oh, it
superior
slipped.
again,
Hold
see?
on, it slipped.
It's
It
left.
slipped.
It's left to superior again.
Okay, good.
Stay
Yeah, that's good.
Stay
Yeah,
there.
that's-
Stay there.
Yeah, I think that you can tent there. A little superior though, huh?
Superior again. Yeah.
It's a little
Slips down.
superior. Can we bring it down or? Yep. Yep, there you go. There you go.
Okay.
So can you show us the tent, please, Stem?
Yeah,
Not the
it's-
balloon? Yep, there we go.
Okay, go.
You follow John. Yeah. Follow the needle. Yeah.
We are more posterior.
I think posterior were okay. Posterior
Yeah.
were okay.
Just
A
watch
little
it
bit more
doesn't
inferior
slip.
if possible.
So the other thing is we can flex the device a
Yeah,
little
I'm
bit.
flexing a little bit so it will
Engage better.
engage the septum better.
You follow, please. Yeah.
Your
Follow John,
dilator's
follow.
already out though, so you might need to.
No, follow the needle.
Mm-hmm.
What do you think, Stam?
No, it's
Advance the
a little
dilator.
bit superior. It's has to come a little bit more inferior. Little bit.
I come inferior, then again we say it's low.
Yeah, very
That's
good.
actually not bad.
Okay,
yeah.
good.
Advance the dilator a bit more.
It's not tenting though. It's not tenting.
Cine that, please. Yeah. Uh-huh.
It's not tenting. Yeah. Explain
So
that.
Gilbert, tell us about an ideal transeptal for MitraClip.
Let's do this first, then we talk.
Yeah.
Wait, let's
Oh,
finish it.
watch your IV pole, please.
Yeah.
Okay, can we?
Cine again for a minute.
Yeah.
Cine?
It's,
Cine?
you can go a little bit upper.
Uh-huh.
That's very posterior.
Stam, Joanne, what do you think? Too posterior?
Yeah, to posterior. Yeah.
Okay.
Now,
Yeah, a little better.
Okay,
Yeah.
can
Let me
we
go by-
just,
let me go by Keval to see what's happening.
that's actually not bad.
Yeah, please can you?
It's a bit
Do that?
superior
Yeah.
though.
Yeah, that's
It's very superior.
that's better. That's better. I think. Can you put the needle, please? The needle. Yeah, the needle.
It's a bit superior, no?
Yeah, it's still superior. If we can come a bit posterior wise, it's good. If we can come a little bit more inferior,
There you go.
yeah, would be great. There,
Right there.
there.
That's actually not bad, yeah. And then now you just need to
Can
go
we just
clock a little bit and you're done, you're there. Yeah.
Yeah, you can come a little bit posterior. Like, little bit.
Yeah, that's
there. It was there.
Perfect, perfect.
Yeah.
Yeah.
Okay, a touch more a little bit. Yeah.
Let's go. Go.
I think.
Go,
I
go,
think
go.
we should do there.
Okay, we are going. Go.
Okay, we are crossed.
Okay, deflate the balloon.
And after that, you'll
Though,
tell
no.
advantage of this versus Baylis, which we have been using all the time.
So Baylis, the difference is that the you go from the SCC to come down.
Ah.
Here you actually start at the atrial cavity. So for the early trainees who are not experienced, that can sometimes risk injuring the SVC, and you sometimes have this windshield effect because it's pre-curve.
Yeah.
This is not a pre-curve, and this is a steerable system, so it's very different that way. So you have more control, especially with TMVR, right? We've done some TMVR cases now, Dr. Sharma,
yes.
and every millimeter counts because it's a very big device.
Yeah.
For TEER, you at least you can do advanced steering, you have other options, but with TMVR, with placement, it's going to be a challenging. I think, did you
But
it's a pop thing.
Gilbert,
Very good. Yeah.
one thing I find is the big difference.
No, just say that. Yeah.
I know this is safe,
Yeah, go ahead.
the balloon. Anchoring to the septum
It's
is not harder compared to
Yeah, you have
Baylis.
to- you have to
In
engage.
Baylis, the needle anchors the
Because
septum
it's
better.
pre-curve. Because
Yeah.
it's pre-curve. So
No.
that's the difference. But you
Also-
can pre-curve this as well.
No, even if
but-
you pre-curve,
Yeah.
you have to remember it's a big balloon.
The
and
balloon
then-
will
yeah,
always slide on the
slide
septum.
on the
So
septum.
the key
So
here
that-
we learn now is to not to over-inflate the balloon tip. Just enough. So
No, even then,
This way.
just the
I know,
concept.
what about anticoagulation now? Is done?
Yeah, so
we
ATT is
gave
well over
usual,
300.
we gave about 2,000, and now as we are talking, as
Yeah.
soon as we are done with the transeptal,
Yeah.
our anesthesia colleague
Stan,
will
can you
give the
show us
full
the height
dose.
from the wire? Were you able to measure the height?
Yeah,
Just
that's
for
what I'm
for
trying to do.
our
That's-
Chinese colleagues here
That's what
to
I'm trying
show.
to do, yeah.
So we only
Can
give
you
about
please press?
2 to 3,000 for the transeptal, then give the full anticoagulation.
So, Dr. Chen and Dr. Fang, any question about this? I mean, you saw the demonstration. This is another new device.
4.3, 4.5.
Okay, great. Thank you.
Yesterday
I
also we
think
had this trouble.
This particular device is safe and effective to transseptal puncture, and I think the pre-curved guide wire can pass very safe to get through the septa and very quick.
This
because whole
puncture
thing- yeah.
is very useful.
Pull the wire.
As you saw, they took their time because we know that the whole case in these TMVR and the mitral clip is where the puncture is. Not a correct puncture may take your 1 hour, but puncture rightly done can complete the case within 10 minutes.
Show us,
We'll show you our
we're
data.
coming up with a guide.
Good. Thanks, Tam.
Sorry. Yeah, well, no,
Explain.
Explain, please. Yeah. Explain, please. Yeah.
Yep. So you can see the dilator is across, and just make sure the guy is across as well. So what Dr. Cooney is doing is the kind of corkscrew the guy slowly in there and gently. If there's any resistance, you go back and then you
No need for
basically.
fluoro, just show my hand movement. Oh,
Yeah, no, you
okay.
need both,
You need the
both,
fluoro.
all three,
Okay,
all
that's
three.
fine.
So yeah, and then you can see it's a bit of tenting. So you try to go the different trajectory. In some difficult cases, you would even actually do like what I call a corkscrew maneuver to do 360. A lot of tenting.
We can
there.
change the camera to the ceiling camera then?
Still tending.
Yeah.
Yes,
We're
yes.
showing it now, hands.
Just stay there with just gentle movement. Not on the balloon.
Mm-hmm. So when you're engaging the septum, you go plus or minus here, Gilbert. What do you prefer? Yeah, so Or do you change that? So when you go minus, you straighten out the catheter, so a little bit more pushability. So that's our preference.
That's
So right
what
now,
we
I think
did
it's
mine.
neutral.
Yeah, I'm neutral.
So you can
want
most
me
people
to go a
recommend
little?
and use neutral, but you have this bit pull more back and pushability, and then
Okay.
you can.
Okay, come out, come back. Okay.
Yeah, so that's always
So
a
you
good
can
technique.
try that.
Yeah, as an alternative. But the key is you don't push aggressively,
Yes.
because the two things that can happen: one, you can tear the septum, which is a big
problem. And number two is that you can actually injure the posterior wall because you're too aggressive, even with a stiff wire. So it's very important to take your time here. In fact, when we teach our fellows, this is one of the critical steps. You know, the rest of steering and grasping, we can,
Should we
they're
change it
relatively
to
straightforward.
balloon dilation?
But
I'll try once more.
No?
but yeah, no, but you can definitely need to be very careful about this movement. Let's bring it
Still
back.
tending.
Let's bring it
Yes,
back.
yes, we know. Damien, balloon.
Just slow corkscrewing movements.
Septum does not look that thick. Or you
But it's
think you're just
elastic.
at the junction?
It's elastic.
Elastic septum.
Why don't we do the balloon?
Try now.
That's where we were before. Wire.
Yeah, wire's okay. Wire's okay.
No, we did. Guide back, we came back. You're saying we're coming back and then going in again? The wire may flip out.
No.
How often we had to do a balloon valvoplasty or balloon dilation
Of
of
the
the septum?
septotomy. I
before
mean, about
advancing.
30%.
30%. 1 in 3
30%
cases.
we do every. I think I would take this out and do the balloon.
Yeah.
Don't get aggressive.
So yeah, let's try to do the
Yeah,
balloon
balloon.
here. I agree. It's a very elastic septum, Gilbert. Yeah,
Gilbert,
let's-
out.
Yeah.
Come.
Okay.
Okay,
Get the sheath
18,
ready.
18 French
Yeah.
clip.
Get me the sheath ready.
You need the sheath, why don't we do without? It'll
Need
bleed.
the sheath. Want to try once more while we're waiting?
Bring the blood.
What happened?
Here.
Okay,
Yeah,
now
popped
we
in.
went through.
Good. So that helps a little bit of
Stabilizer,
corkscrew,
please, and the
Advanced.
Take this out.
and the mat, please. So we have a lot of guy across, which is okay, as long as you have a wire, right? And then so you can always bring it back. Short axis, please. Explain. So just like what we
The
do,
guide.
the dilator comes back
Dilator.
first to make sure you can see that the
Where is the guide?
The-
Can
the
you show
guide?
the?
Stam, can you show us the guy, please?
Yes.
Stam guide, please. Thank you.
It's
Okay,
quite
good.
quite a lot of guys.
Quite a lot.
Yeah.
Okay,
Okay. And then so we could
So
add
the
wire.
dilator comes out first, and then we take out the wire, and you see
then you
here,
can see.
syringe. Yes.
Okay, that's fine. Okay, so so Professor Chen, you can see here, this is what we do with the pressure line, and you can do the same with the G3 system. So we do that, and then we flush. Go ahead. To
So
clear the
this-
fluid, and then we actually,
Clear all the blood from the
yep, and then once we do that,
introducing area.
so that we can see the blue, and then we stop, and then let's see what the left atrial pressure tracing is.
Show the pressure tracing.
Yeah, so after this, I put the clip.
0.
You need to follow the clip, okay?
I know.
Yep.
Please. I will pull him in now.
You're
Okay.
pulling the guide back.
Yep.
Lot of
Okay,
guide.
so what's the pressure? Can we let the
Re-zero
audience
it.
know? It's
It's
23 and 35. Okay, can you give two more
Can
down?
you see the pressure?
2 more
Yeah,
thousand
let
of
us
hap-
see the pressure, yeah.
1 second.
Show the hemodynamics, please. Yeah.
Put
Yeah,
the,
now
what
it's
you should do
okay.
is put the hemodynamic in a small,
No, they
in the
can't do
side.
it.
Yeah, on the top of the echo.
Okay, good. Okay, good.
Okay, we're going because they need fluoro also.
Yeah, you need fluoro and
We are doing blue to
yeah,
blue.
you can take the hemodynamics off now.
Now put, they all 4 of them are there.
Four of them. Good,
Yes, yes,
excellent.
that's
That's
what we said.
fantastic.
That's
Okay.
why I said small.
All right, Stam, our clip
Picture
is
in-
coming out.
Yes, sir. Yes, sir.
So what you do is you come out as you're coming out. First thing,
Yes, so follow you.
gentle, and then you straddle.
Follow the clip,
You're
please.
straddling here. Looks good. Straddling is
Good.
done.
Okay, let's back
Right.
in.
And the first movement will be, we'll
the
go
clip, yeah.
medial,
For the clip, yeah.
posterior. So I'm doing the M knob.
For the clip, please, yeah.
Yeah.
Follow,
Just
follow,
make
follow.
sure we are clearing the Comodine ridge.
Yeah, coming down. Follow, please, follow.
Keep adjusting your straddling.
Follow the clip, please, yeah.
Going up posterior. So right hand on the M knob, left hand on the guide to go posterior.
Yeah, yeah. Can you do tip, please?
Okay, bicommercial explain now.
Yeah. 65.
Okay, watch your IV pole. Make sure your
Okay,
IV
please,
pole and
explain,
stuff are
please,
all
explain,
cleared
please, explain.
on the anesthesia side, please.
So
Yeah.
come a little anterior there.
Yeah.
Just tad bit.
You increase the gain a little
Let's
bit.
straighten the clip out.
Yeah.
Yeah, we're coming anterior.
Oh, beautiful, beautiful.
I'm going to add a little plus just to get
Okay, please, on the top of the clip,
Trajectory.
please. On the top of the clip.
better. Okay.
Follow the clip, please.
Okay, let's get a proper bicommercial view, and then we can show the audience how that's done.
Okay,
So-
please explain.
Okay.
Explain. The posterior.
I added a little plus.
You can see
Yeah.
these elastic septums. You can have a
Want
little
to
bit of
open?
septal fatigue from the get-go.
Yes.
Yeah.
It drags down and your clip is
Want to
somehow
open
in
the
the
clip?
valve.
Can you show us the more atrium? Is that possible to show us the trajectory of the clip on the bicommercial view, please? We don't need so much apex. We need more atrium.
Explain, please. Yeah.
And it's a little rotated, right? You see that? So you have to be very mindful of that rotation. So what we can do at this point, since you're already on the clip, then we can raise grippers. Now this is different from G3, right? This is, we have to unlock and then we open and we have to actually check the grippers
Yes.
to see which is which. So there's a tactile thing on the one of the grippers,
Yes, take
and then you
picture.
say tactile coming down, and you can see it's posterior, right?
Posterior, yes.
Okay. And then
Posterior.
you have down non-tactile coming down.
Anterior.
You can see it's anterior.
Yeah.
Okay, so now what we would do is go 3D.
3D,
So-
please.
This is for independent grasping if we need
Yeah.
to optimize.
Correct.
No, higher, yeah.
Okay, we need space in it down
Yeah,
in the
yeah.
leg of the
Please,
IV pole, please.
I need some space here.
So this independent grasping is only available in
Can we take this
G4.
out, please? Yeah. Man.
So if you see the hemodynamics, your V waves have gone up. That's because the
We're on top of the
clip
Take
is
it away, please.
engaging
Take it away.
we're on top
the
of
valve
the-
leaflets.
Take it away, please. No, take it away. Take it away. It's okay. No, take away the thing. Yeah.
Okay, good.
Take away the thing. It's okay. The radiation is good. Let's do this case. Okay, please. Let's work. Explain.
Yeah, we
Yeah,
can go
3D,
3D
please.
now, Stam. Yeah,
3D.
thank you.
30, please. Turn around. Turn.
So when we teach
Yeah.
our fellows how to do this, we
Yeah.
boil it down to very basic views because we don't want them when they're in practice. They might work with other different images of different skills.
Turn around a little bit more.
So the key for the 3D
Right on the
on-force
top,
here
right on the
is
top,
to
please.
have a 10 and 2
No, clap,
orientation,
clap,
right, in terms of commissure. So you can see it's a little bit rotated.
I'm
And
going
so we
to
do counterclock.
Counterclock here. So very simple, like a
No.
face of
They
the
got
clock.
the clip.
So I'm going to do counterclock to go to 10 and 2.
No, so
Wait,
so be
hold on.
12 and 6 there.
12, 6, hold on.
Little bit more counterclock.
Yes.
Yeah, beautiful. That's great. That's great.
Inside the
On the
valve,
on the
Good,
on the
good,
flare
good,
leaflet. On the flare scallop. Yeah.
Okay.
Okay.
Take some parallax off.
Take that, please. Take that.
Can you drop the gain to show us, please, in
Yeah.
terms of the on-force?
I think we're more posterior. Huh?
Okay.
Little bit anterior. And you have a medial dive there.
Okay.
I'm more posterior. I'm
2D?
going a little bit
No, not Jack. You have to show us a nice 3D, please. Because I think we're too much counterclock now. Right? Can you show us a really nice on-force? Yeah, I think that's better.
Can we go down now?
Please explain, please. Explain.
You're
please,
already
yeah.
in the valve.
Okay, 3D, please.
Oh, we're on the valve already.
Yeah, make it smaller.
That's what I've been saying. You have a lot of septal fatigue, so that's
Make
why
it
it's
smaller,
falling
yeah.
into the.
Okay, can do 3D now.
Yeah.
3D zoom. 3D zoom, please. Yeah.
We're underneath the valve already because there's not.
Okay.
We have some septal
Okay, go
fatigue
ahead.
from the
Yeah.
being very elastic.
Okay, turn a little bit to do the zoom. Yeah. No. They're under the valve now.
Okay, let's.
Okay.
Okay, let's.
How does it look to you, Stan?
Yeah, it looks in good position, bro. Good position.
12 and 6.
Yeah, 12 and 6.
You
yes.
happy?
Yes.
Okay.
Okay.
All right.
2D,
So
please. 2D.
2D, and let's take
Okay,
the parallax
explain,
out
please.
to make sure. Okay. We're a little bit. We're anterior is on, so but we're a little lateral. Huh?
Mm.
We want to go in and go a little bit more.
Okay.
Yep. We're free now. So we go a little bit more medial. Yep.
Okay, please follow the clip, please. Yeah.
I'm going a little posterior.
Okay, you have both leaflets.
Yes.
You have both. You have both.
Yeah.
I'm pulling back.
Yeah, and
little
come up.
posterior.
Come all the
Both
way
the
up.
leaflets are in.
Come.
Yeah,
Yeah.
all the way up. All the way up.
I'm pulling
Posterior.
back.
Good job.
I'm
Taking.
pulling back.
Taking both. Yep.
Yes.
Yeah, take it,
drop
take it,
both.
Guard them.
Take it, take it,
Okay.
take it, take it.
And now what we'll do is to close a little bit first, then you lock. Close completely. I'm going
Give
to
back a little bit, yeah.
give back a little bit
Mm-hmm.
to remove some tension.
Mm-hmm.
I'm going in a little bit into the ventricle. Yes.
I think
Good.
we lose some posterior.
Okay.
That's okay. Yeah. That's
Good.
Okay,
Okay.
on the clip, please. On the clip.
I
He's
think-
saying is you want to show some color or no?
Yeah. Yeah. Let's put some color, please.
Wow.
Nothing. Take bigger, make it smaller. Make it bigger, please.
Looks good. Huh?
I think maybe optimize posterior here.
Yeah, you need to optimize posterior. Yeah.
Maybe. Let's see. I don't see the V-way come down. Though. Let's see. Stan, can we get the look at the whole valve for the bicommissural view, please? Okay, take your time. Let's just look at the entire valve so that we can see both medial and lateral. Right now, your medial is not fully in view. Yeah, that's better. That's much better, right? Okay, so let's show that and to our audience
let's put
here.
color, please.
Now we
Let's
can
put-
do explain.
Explain, please. Explain. On the clip, please. Yes. Okay.
Okay, so
on the
I
clip,
think
on the clip, please. On the clip. Yes.
so. I think we need to optimize the posterior, number one, and number two. Let's show some color now for our
I'll
audience.
put some
We can
color,
see the
please.
entire.
On the
Actually, better than expected.
clip. Yeah. On the clip now. Make it. Yeah.
So we don't check gradient here. It's very
No, no.
important. There's no need. It's
Yeah.
a big valve. So here, what we would do, we would optimize here. Okay.
Yeah.
So the steps to optimize as follows. So Dr. Keeney is going to get the device ready, and then I'm going to basically unlock the clip. We leave the grippers down. You don't leave the grippers up. Okay. So we're going to open, and all she's going to do is just going to swing posterior. So go posterior guide torque to get more posterior. Focus on the posterior arm, please.
Posterior.
Yes, yes. I'm
So
going
Dr.
posterior.
Keeney is now doing
And,
posterior.
same, this movement has to be
Very, very
tiny,
small, very small.
movements.
Okay, you see that now?
Yes.
So posterior is tactile, right? Okay. All right, so I'm going to raise now. So she's going to go more posterior.
Good.
Okay.
posterior,
Okay.
please.
I did.
All the way to
Okay,
the
good.
end. You have it
Okay,
all.
I'm going to drop now.
Yeah, you have it all. You have it all.
You have everything.
And again,
Yeah.
see that? Just that motion. You can see the nice bounce.
Yeah. Yeah.
And then I'm going to close, lock early. And then we're going to close very slowly. And she's going to give back tension
Or torque posterior.
while I try to.
Yeah, careful. You don't
Yeah.
do that much.
Fun a little bit.
Yeah. Okay.
But I
all right.
think MR
So
reduction is
we
very
didn't-
good.
Didn't see that much.
Right, Stam?
Yes. Very good. Yeah. It's
And one
It's gone.
clip should be okay.
It's gone. It's gone. Not.
Yeah.
Nothing. Minimal.
But like he said, can you see the valve rather than more LV? Shows the valve
Yeah.
better.
Yeah, let's do a 3D to see. Again, do a good bicommissural view, please. You can take the time. It looks a little spun, I agree with you.
Okay. Explain, please, dear.
So the only thing that we don't like is that there's a little rotated, the
Okay.
clip
Can you
on
put
the
this- can you-
floor.
Okay, we'll do 3D, please. 3D.
Because it should not have, because we took the parallax already. So let's see how the 3D
Okay.
looks.
That's too big. But anyway, take the 3D, please. Okay. Take it around.
So if you have a little rotation, once it looks okay right now,
It might
once you
get
release
worse,
the
so we
clip,
have to be
Okay.
perfectly sure.
it tends to leak
Okay,
more
increase the
once
gain
you
of the
release the
3D.
clip.
Yeah.
So
The leaflets.
I think we're a little rotated here.
Yes. Can you turn the aorta a little bit more? The aorta a little bit on the center.
So it's 10 and 2.
Please.
Yeah,
Yes, yes,
perfect.
yes.
Okay.
Take that, please. Take that and put some color now. Put some color, please. Nothing.
Beautiful.
Nothing.
So are you sure the orientation is okay?
Yeah, amigo. It's perfect. Can you take the color off? Okay. Take the.
Professor Chen and your colleagues, what do you
the gate
think?
down. The gate down. The gate down. The 3D gain. The 3D gain down. Yeah.
Can Professor Chen hear us?
Yeah, I think
What do you think?
these were exciting results. And my question is, like you have said in the first, you want to maybe one or two clip strategy. If you want intentional two clips strategy and bailout two clip strategy, do you have some different about the strategy? The position, the first position of the clip.
Yeah, very good question. So go back to the bicameral views, Sam, please, to show our audience.
Yeah, take the color
So
off,
what we
please.
would have done here, we would start a little bit medial. That was the idea, because the broad prolapse, and you can see and flail, but you saw in the 3D earlier, the flail is actually gone. And so I think we might be able to get away with one. Remember, when you put a second one, there's always a chance to distort the valve. So if you can do the job with one clip, that would be ideal. And I think the Gen 4, G4, allows you to do that now versus G3. I would say if you have G3, this will be a two clip case because you don't have the wider clip. What do you think, Dr. Kinney?
No, I agree with that. Or as soon as we finished the clip, remember that we had almost negligible MR, but here now we see a little bit MR on the
You want me to
medial side, huh?
Yeah, let's
show
show
you guys. You want me to show you? So on the clip.
Yeah,
Yeah,
this is on the
yes,
clip.
on the clip.
On the
We want
clip,
to see, go back.
Nothing through the clip. Okay.
Okay.
Moving medial.
Yes.
Nothing. Trivial.
Okay,
There,
yeah.
see?
Trivial. Yeah,
Moving-
there's no prolapse. But the key that Stam is showing us, there's no prolapse residual on
Moving-
either side.
Yeah, moving lateral. Nothing.
Right? So Professor Chen, I
I
think
want a confirmation on the 3D also.
I think the key
Yes,
is
yes,
that
yes.
if you have residual prolapse or flail pathology, you cannot do one clip. You have to move that to take care of that, because that, when you release the clip, you're going to have a jet. So I think that is the difference.
Okay, let's see on
I
the
think-
3D.
I think this
Yeah.
is a key message. If we have some residue prolapse, maybe we lead the other
Yeah.
clips.
Right. You would have moved this
Nothing.
more
Dr.
medial
Kinney.
and put a second one lateral. Good.
Nothing. It's
Okay.
Absolutely.
So if everybody agrees, then we are ready to release.
Yeah, great. Amazing. Great. Yeah.
Yeah, let's check the gradient in the pulmonary vein flow just to be
Yes.
sure.
Yes. Yes.
So what we do here, you can start the process, is go to an LAO view. Okay, you want to make sure the clip is not opening up. Okay, so we keep, what we do now here,
Now
if you
can
look
we
at my
show
hand,
the ceiling camera so we can show the release? Yeah.
so the finger goes on the
lateral.
lock lever so it doesn't come back up, and we open to check. You can see on floral. Sometimes there's relaxation with the G4 or the XTW, but that's okay. So there's no opening of the clip, so I go one turn pass, and then I go tight again. You don't have to be too tight.
4 and 3.
That's it. Okay. So
Now,
now
other thing is, before
Check up.
release, we always check. I know you mentioned don't check the gradient, but if it was for a secondary MR, we would always check a
4
gradient,
and 3.
right?
Yeah. 4 and
That's
3.
one, and other one is make sure the insertion is very good. Stam, you are happy with the insertion?
Yeah. Yeah. Insertion is all the posterior leaflet is in. The anterior is all in. The gradients are 4 and 3.
Good.
so it's also important to hold your
The
lock
pulmonary
lever here.
The
You
pulmonary
check
vein
floss.
normalized.
Good.
Normalized.
So you check your floss one here, and then you floss, and then you remove the other one. So you don't need to floss multiple times with G4. So just once, and you go parallel to the handle. This is even more important in tricuspid. Do it slowly. So Professor Chen, I don't know if you have any experience with MitraClip in the tricuspid position, but this is actually very important because the tricuspid leaflets are thinner. So you have to do this step even slower than what I'm doing right now.
Okay.
Okay. So that's done. So now you go back, stay on this LAO view, and you do the same thing again, open, to make sure there's no relaxation, and you do see then that's not. And then so you go back to neutral, and then we typically go back, what you had to the RAO view. So we can see the shaft.
And then so to take the pin out, this is pretty standard procedure. So we teach our fellows to do this step first. They have to master this step. You expose the groove and you make sure you see and feel the groove. You want to do that?
Okay, ready, go.
And then so he's going to do 8 turns. We do 9 for good luck. Okay, and then the pin is out.
Yes. Slowly
Just wait
release
for
the
it to
clip.
come out.
So we
Yes.
wait. Yeah, stand all the way up.
Did you do 8, 9 turns? I think you did.
Done. Good.
Okay, good. So you see very stable.
So we had a lot of M, so undo the M.
And then we bring
Slowly
it back.
and
And
bring
then
it
we
back.
bring the plus. Okay, let's look at MR now. And we'll get
And we can see the hemo, the V
Stan,
waves.
can we look at the MR, please?
Yeah.
Okay,
Very
minimal.
nice.
Right stamp?
Yeah, minimal.
So
we
you can
can-
see that this is what we expect for TEER. Remember, there's always tension in the clip system a little bit. And then afterwards, you know, when you release, it can actually be different. So just keep that in mind. Flush, please. Thank you.
Nothing lateral,
Okay,
nothing
good.
medial. As you
Okay,
can see, nothing medial.
Good. Keep flushing. Off, please.
And nothing,
What's the map now?
nothing lateral.
Thank you. So you can see our V wave did come down. So
That one leaflet.
Normalization of the
Yeah.
pulmonary veins. 4 and 3 gradient.
very nice. Stan, can you show the audience the clip again, the position?
Yeah.
Very stable. No residual flail, no residual prolapse on either side. So that's kind of the result that we want. You know, I'm a cardiac surgeon, so if this is a patient, a surgical candidate with a primary repair, you want to have mild or better for primary amount. Dr. Keeney, any comment on this case?
No, I think
Sahil, any
Pretty
comment
good.
on?
Yeah, so I think there is a tiny bit of MR which looks more than when it was being released, and that's because of the natural laxity of the valve and how the clip sort of sits on it. There's a little bit of you know, it was a little bit rotated, but that's expected. I would not go too crazy about it. I think this is where you say you've done a good job and you walk out of the room. I don't know what you guys think, but
Yeah,
Absolutely.
yes, it's good.
You can see the orientation is actually good. You can show
Yep.
Stan show the 3D now. It's 12.6 where we started, and actually 12.6 despite you see some floral changes. We don't like to see floral changes, but in this case, I think it was fine. It was just because we optimized may have changed. But you do when you try to stay in the same floral orientation. That's the key, because echo may not be able to show you otherwise. So I think this is an excellent result for this particular patient. And Professor Chen and Professor Yang, any comment from our Chinese colleagues?
Take that, please. Take that.
and you can see the V waves definitely improved.
That's the question. If you, the patients need another clips, which kind of clips you will choose? Which types?
So if let's say this patient come back, we will choose a narrow clip, because what we find with G4 that if you can you change the camera position,
Yes.
please, to face
Come
us,
down, shows full.
the front camera, please, rather than the side camera. So I just want to show a point here. Can we change that, please, the live camera?
I'm gonna go to one for you.
We need that camera. Yeah.
This is wonderful.
Yeah. So
Felipe,
okay. Anyway, so I'll try to show you here.
hold on.
So-
Can you show the camera full to
The front,
Dr.
yeah, the
Tan,
front one,
yeah.
please. Yeah,
Yes.
no,
you're good. Go there.
Okay, here. So what we're saying is that this is the XTW, which is a wider clip. So the second clip, we now realize that it will be a narrow clip. If you put, we've done cases from my experience, if you put two wider clip next to each other, there can be sometimes a jet across. So that's not good. So we now actually like to have a fat clip, we call it a fat clip, and then a skinny clip. Next to each other, you can be closer to each other.
Unbelievable.
So that's our strategy. So I think as we do more of these cases, we'll learn more as well. But with G3, what you have is that you can put two clips very close to each other, which is great. So you do rarely have to jet across. But with the W, you have to be careful about that.
Yeah. No, so
Yes.
yeah.
Okay,
Slide
thank
of our
you. Thank
timing.
you very much.
Our timing
Okay.
outcomes slide.
So Dr. Sharma, you want to
outcome
close
slide.
the session?
Yeah, we have everything. Yeah.
Then we're going to bring the guy back to the
Rational,
right
rational.
atrium.
Yeah, please, yeah.
Of course.
Okay, we're in the right atrium now.
10 minutes.
So make sure you go negative on your guy before you take out to the right atrium.
Okay. All right. So great demonstration. and worked out very good with one clip.
Yes.
Wow. This is wider clip.
Congratulations. Very, very fantastic.
You
No,
need this G4
one
clip
wider
is really
clip.
working out very good.
And usually in a primary,
Yeah.
if we get it at the right spot, once one clip is good enough. Yes.
Okay, so let's just show we always try to show the latest in the subject, and that is about the transcatheter mitral valve intervention, data of the 5-year of the COAP trial, and then from the TVT registry, particularly for the DMR, then there are heart failure stages which have come, expand G4 registry which we have shown today, but some data, then co-opt and MitraClip Pro scores now for TEER outcome, then very important study, that is impact of TEER MVR on surgical volume and outcomes, and then of course the new TMVR system which I will show. So 5-year data which all we know, original co-op trial was presented in ACC, published in NEJM, showed the sustained benefit of reduction in heart failure, hospitalization as well as death, and of course rest of the points as you can see here. But what is more interesting is basically if you see the real benefit was in first 2 years, and after that it kind of overlapped. Reason is why. After 2 years, patients were randomized, those who are not randomized, those who were in the control group crossover. And this basically was the reason that 67 of the 312, because remember 169 has already died by 2 years. So these are the 67 of 312 got the clip, and very interesting, their outcome was similar to our device. So even if you started your clock at 2 years, the outcome was similar to the device in terms of the death or heart failure hospitalization. Very interesting observation. Second, safely, even on the long term, oral safety event just shows you that device specific event is very, very low. The detachment, embolization, all are less than 1%. So this is a very established technique. Second, this is the data presented again in European Society by Raj Makkar of the ACC TVT registry, large number of patients, non-emergent, about 19,000 plus. As you can see, of course, these are the high-risk patients for the degenerative mitral regurg, because right now in United States, degenerative MR like this will be done only after surgeons will write it off that surgery is not a better option for this particular case, and most of them are moderate to severe and severe. Overall outcome in these high-risk patients is still quite good. Mortality of less than 2.7% and readmission 2.6 at 30 days, and rest shown there. And more importantly, that the outcome is improving, that residual mitral regurgitation. Less than 2% is almost in everyone, 98, and less than 1% in 77.5. Gilbert, want to make comment on it? Less than 1 is 77.5.
Yeah, no, there are a number of limitations with this paper because first of all, it spans 3-4 generations of MitraClip. This is not G3, this is not G4, it's only a small percentage. 2 is that it's all operators, all comers in the United States. And so, there's definitely the reason why you see only 66% at 30 days of 1+ or better MR. So before, you don't have the technology to optimize your MR repair. Now you do. And so really, there's no excuse now in our mind that you should have 1+ or better in primary or even secondary MR if possible.
Beautiful, and that is what we will show. We are reaching there, and basically they could talk about the success is 2. Less than 2 equal or less than 2 plus mean mitral gradient of less than 10. As you saw it, then you can measure the mitral gradient, and this actually had translated into a various degree of outcome. Success rate over the years, you can see here from 2014 to 2022, a significantly increased from 81 to 92%. And of course, the volume, which is on the bottom, has increased also. So about roughly said about 16 to 1700 of the mitral clips are being done overall in United States per month. About little less than 2,000 at present. Now mortality, if you are successful, unsuccessful, clearly shows that it's a double. If you are unsuccessful, successful 14%, which is good. And remember, successful is 2 or less mitral rigors plus gradient less than 10. And this translates into heart failure readmissions. And so also, whatever your residual mitral regurg or the gradient, outcome are there. So key is you have good results, less gradient, your 1 year survival is the 98%. and sorry, 88%. So this is a success overall in the trial, taken all people together. And of course, you see some of them have mild, moderate MR and unsuccessful in about 11% of cases if we take all the patients together. So then also for the degree, so according to MR success, so same, that whatever degree is mild, none, and of course with the gradient, all are speaks for there is a gradient of survival. So better is low gradient and less than 1 plus MR. And this emphasized that over the last 8 years, I'm reading the last line, 8-year period during the study, the procedure volume and success rates increased significantly, reflecting procedural refinement and device improvement. And this is where we are now. Now then there is some data came that we always wait till end stage for the heart failure patient for the functional MR. The question is, should we be waiting that? They have 4 stages. They have come up with a stage 1 when their LVF is low and LVDP is high. Stage 2, there is LA involvement, and in a stage 1 there is no LA involvement. I mean both LA involvement, and then stage 3 and 4 where you started having a volume overload. And question comes that if you do it in early stage, although there are very small number of patients, you get the best benefit. So always question comes, just like for the tower, you are asymptomatic but you have severe aortic stenosis. Should you wait? Right now we all have been taught you have to be on guideline directed medical therapy, and then follow up. And we have seen patients that some improve and many of them they lost follow up and they come back 1 year later. Now their ejection fraction from 55 has gone down to 20. So question comes, you have severe functional mitral regurg. Should you wait to get a pressure and volume overload of stage 3 and 4 or the biventricular failure? What do you think? I will ask actually our echo colleague also STEM on this point.
Yeah, I think earlier is better. I mean, because if the ejection fraction drops, you know, one of the exclusion criteria also for this clip is ejection fraction. So that means that the lower ejection fraction, the worse the outcome will be after you do it. So I think the earlier, the better is for everything else, or the valve disease, the sooner the better.
Yeah, so good. That was the conclusion.
Yeah.
And the second is now the edge-to-edge, the expand registry. What basically is, I already mentioned, the NTEER and XTR and of both classical versus the new generation. And they actually have done by using those the overall the large number of patients from the registry and used for both primary and secondary MR, XTR. What is the most common clip we use at Sinai at present, knowing that we do now this year we should do about 100 clip procedure, mitral clip, which is the most common and what is the second?
So I mean it depends on that, but G4 is G4. I would say XTW is the workhorse clip.
Okay. So
the bigger and wider.
Bigger and wider. So that's the simple answer, because that's why many times we think 2 clip and we come out with the 1 clip on those cases. So procedural success of the expand, as you can see, significantly improving, and of course the procedure time is going down. So this is the whole purpose and length of stay. Fluoroscopy time, everything gets better, lower residual mitral regurgitation with the bigger clip, and comparative data from by other studies with the TVT registry co-op for the primary and secondary MR using this bigger clip has a better outcome, and really this has led to another multi-center G4 post-approval study, which basically are putting together all the data of these patients from an international point of view. All these patients are symptomatic, we all know, and question is that if you have a TEER suitable and TEER not suitable, where there is a risk of stenosis or inadequate MR reduction, there also it helps. Any comment from both of you on this issue?
Yeah. Dr. Kinney, want to
even the bigger clip is allowing you to take some cases which would not be done in the past?
No, that is true, especially I think in secondary MR where you have dilated annulus. In the past, with a smaller clip, you know, 3rd generation and all that, we were not able to take on those cases. But definitely with the increased length and wider, That is how we were able to do this tougher
Yeah,
cases.
Stem,
But going back to
let's
your
hear from
question
Stem.
also,
How many, like, quote unquote, yellow cases we get, right? Green cases, almost, we don't ever see them.
we don't see
You want
that.
to comment on the complexity? You seem to see all the echoes.
Yeah, I mean, it's, evaluating these patients are very difficult,
Yeah.
and so.
But I think the complexity is high.
High, very,
right?
very high, yes.
In terms of the hill, you want to make a comment about, they all talk about green, orange,
Yeah,
red,
no,
right?
I think the biggest benefit we
Yeah.
have now with so many choices available is if you look at the concept behind the procedure, which was the Alfieri stitch. Unfortunately, only Alfieri was the one who was able to reproduce the outcomes. Rest all thought, adding annuloplasty to the Alfieri stitch would give you the best outcomes, which was reproducible. So I think with these wider, bigger clips, you are able to achieve annuloplasty as well as the stitching of the leaflets. So I think there is definite benefit of having these choices, and especially using the bigger clips in some of these cases, especially secondary atrial MRs.
And that is a good point, that now we use less clip, I mean a smaller one clip, and then lower time used and less gradient, and of course the lower regurgitation which happens. Now, there is another interesting, the impact of mitral regurgitation etiology on mitral surgery after TEER. You got the TEER, now failed. Now the patient needs the cutting edge registry was to get these patients follow up, what happens to them. And as you can see, the numbers are increasing because more cases, clips are being done. They both are kind of equal, both for primary and secondary MR, as you can see there. But the important point, of course, from a risk point of view, we all know that functional or strict secondary MR will have a higher comorbid conditions compared to primary MR, and when they go for, and of course the ejection fraction point of view, and particularly what I've seen, that once you failed your clip, it's about 3.5 months, around 100 plus days, then patient continue to be symptomatic and they go for mitral valve surgery. What is our experience here?
Well, we've done a few, but most, stenosis is one. I think that's important. But the secondary arm is that you cannot clip more without causing stenosis. So they have ventricular disease, right? It's not a primary disease. So those we have to manage. But almost the key message, almost all of them get mitral valve replacement. Like maybe around less than 10% you can repair the valve. So the message is that, if you want to do TEER, you want to do a good job from the get-go. You don't want to do a suboptimal job, and then you have to have surgery, because surgery is very high risk. I'm sure Dr. Sharma will show the slide. It's a very high mortality associated with secondary MR over primary MR in this paper.
And most of these ultimately go for, because there is a still regurgitation remains, and then the question comes in here, mechanism of the TEER failure is a loss of leaflet, insertion single leaf detachment, then partial detachment, clip embolization, but majority are mitral stenosis, residual MR, and recurrent MR. So those are the major, they makes it 70-80%. Everything else is very small. And that kind of equal both functional and degenerative. So I felt that maybe the residual MR leading to surgery will be more in the functional MR, but it's secondary MR, basically they call it here secondary SMR rather than FMR.
Right.
But it was not the case.
Well, that's residual and recurrent, right? They're two different things. So residual, you leave the room with MR, and then recurrent, they come back.
Right.
But also, we noticed that there's more stenosis on the secondary MR side.
Right.
As well.
That is true. Secondary more stenosis, but residual MR were equal.
Yeah.
Both of them requiring clip. And 30-day mortality, as you can see, clearly higher in our structural versus primary. And one more thing I wanted to show, and that's the point you made. Why we go? 1 second. Yeah. That what do we do? Most of these cases, then surgical approach is basically the replacement of the valve.
Yes.
See, mitral valve replacement or repair, 90+% gets the replacement, and repair is done in very small.
That's right.
So that is where, and then of course with the particularly in the degenerative, there is no repair actually.
Yes.
It is almost a replacement. So this is another mortality, and so this basically is stratified, is very important. Overall, it's a risky procedure now. You think about 3-year, 32% mortality. And it's a big difference in the functional or secondary. As you can see, primary MR, 80% survival at 3 years, while if you are secondary, it's only 40%.
Yeah, they're sick patients. I mean,
Because
that's why we
they're
don't
sick
operate
patients.
on them
Yeah.
anymore.
So that's it. So and I'm surprised they actually did, and this nice graph central figure shows all these points that if the secondary MR has to go for surgery is higher risk, and it usually happens just because of the continued regurgitation, as you can see here, mechanism of failure. So this is the cutting end. It's very important. The risk of mitral valve surgery after TEER is non-trivial, with higher mortality after surgery, especially in secondary MR patients. These findings provide valuable data for further research to improve this outcome. So then question comes is that if it is a bad etiology, should the patient go for surgery, which is like same thing, which we always talk about, but all these patients went for the clip by definition because surgery was not appropriate at that time. But once you failed, you had to go.
Yeah, I mean, either you tell them no, we can't offer anything, medical management, or you trap to do high risk surgery. So.
Okay. Good. And then we have you remember the Pascal is the new device we have showing good data of initial Pascal implant, and then there is a small randomized trial which showed Pascal 2D about 200 patients overall, showing the data that clearly maybe the device issue, that mitral clip faster, we all know, compared to the Pascal, and rest of the data looks like similar complications and so, and this is the short endpoint and safety, but equal, effectiveness equal, and this is actually Sinai data. As you can see, we have over last 6 months, if we take Mount Sinai Hospital versus National TVT Registry, the biggest effect I would say here is one, the average device time, less than half of the country, 25 minutes. Today was what, 12 minutes, 15 minutes or 20 maximum. And the second point at the bottom, of course, we do great in terms of average MR reduction, which is 1.1 versus 1.3. That mortality, 30-day mortality is 0%, and 1 year was 5%, which is 3 times higher for the national. So this is a tremendous, I would give a thanks to our great structural team. All the members are right here in this room. So just lastly, quickly, that like everything else, there is score coming up, co-op risk score by from the co-op trial by Greg Stone, which takes COPD, AFib, heart classification, CKD, LVEF, right ventricular pressure, TR, and all those takes into account, and then you can have a score from 3 to 15 and gives a follow-up 2-year death or heart failure. So with that note, Abbott actually had asked Anu, she is the master of making the app to create an app for the co-op risk score. So purpose there is you can better plan your strategy.
Which patient should be getting what kind of treatment? So as I have both the interventional cardiologists, surgeons, and heart failure people, everybody can use that app and give a risk score. And when they're discussing with the patient, outcomes will be will come out as a PDF that they can discuss with the patient. That if this is your risk and this is going to be your outcome, and we document that in the EMR.
Beautiful. Another risk is from the Mitro Pro from German registry with from the residual mitral regurgitation. This is also took a mitral score less than 3 or more than 4. These are the ingredients of that score: echocardiographic, MR grading, LA pressure monitoring, LV angiography with the MR regurgitation, echocardiography, and LVOT and various other factors, which is 1, 2, 3, 4 total score, and shown that if the score is 3 or 4 and above is associated with 1 year mortality. So key is the lower score. Of course, everybody wants to have lower score compared to the higher score and so. And this is very interesting that maybe the question comes, once you have such a higher mortality of 50% at 1 year, should you not be doing the case? Right? I mean, there's always question comes out when we do a, let's say, valve in MEC. They have a very high mortality. Maybe you don't do anything. Maybe the patient might be okay. But this always remains the issue. But at least the scores are there now, will be available. Apollo, we are part of it, Intrepid TMVR. which is the transseptal, to have a great success. How many cases we have done so far?
I think almost 10 now.
10.
Yeah.
And you see the 30 data which we presented before. There are no PVL. There was a vascular complication and ASD. Those things are being worked. Vascular complication was the big one, but very good device. Little cumbersome, but that's the, any new device happens, then a very large sheath. That's the key. And of course, one of the device has been stopped at present because of the issues, but we continue to do. And 1 year data will be presented in TCT this month. So another inno valve, which is that there are a lot of restriction of various valves, and this actually works in the very simple, innovative way. And they showed the cases in European Society of Cardiology that is basically transseptal, and you see go through the same for the mitral valve and comes out in various prong approaches, as you can see there, and try to take all your leaflets, very little, and then it opens up the valve there. So after taking all the chordae and make the valve, so seems to be something apparently cause immediate improvement in ejection fraction. Patient with a low EF, but need to see a little more in these particular cases. So this is the trials are ongoing at present with a twist trial to see how it's going to behave. So let me just complete my presentation with a 5-year co-op trial. As positive, even you receive the clip after 2 years. As long as you make it to 2 years in the trial. Secondly, the TVT registry showed the learning curve and great success now, and of course dependent on residual MR and the gradient, and better outcome always in the degenerative MR, and TEER availability in the better outcome of the mitral valve surgery. And then lastly, baseline procedural scores able to identify the patients who will get better outcomes after TEER, and will help in planning. So very quickly, 3 questions. Following statements are correct for 5-year outcome of the co-op trial for moderate to severe MR, except sustained benefit in heart failure and death, sustained lower mortality, benefit after 2 years, landmark analysis decreases in the device group, and patient who received device after 2 years had poor outcome as the original device group. Answer that wrong is D. Even after 2 years, they got the device, they had a similar outcome as if they had a clip originally. Second, this statement is true regarding the TEER outcome in the DMR versus FMR. Significant reduction in MR up to 1 year in both groups. Significant reduction in New York Heart Classification. Similar mortality at 1 year between DMR and FMR, and procedural success continues to increase in last few years. Clearly, the difference is in the mortality, higher mortality in the FMR versus DMR. Then, following statement is false about the concomitant TV and mitral valve TEER. So this is actually overall was a combination of both, and basically showing that B indicated in combined pre and post capillary pulmonary hypertension patients. So with that note, I'll stop here, and any questions we can take.
Yeah, very last talk. One question. How about the future of the TAVR procedure in a trial FMR? Because the number is not real, especially in China. Do we think the TEER is? I think it's doable, but how about the durable and the benefits to this particular group patient?
So I mean, if we take the patients of the co-op trial, and now we go up to 5 years, so those are the TEER, that is still what done with the old devices. So it still remained, the mitral regurgitation still remained low. I mean, it's there, but continues to remain low. The device-related safety remained good. So I think those are still, once you achieved good outcome, I would say it's sustained.
Yeah, what do you think?
I think, like you showed the green and yellow, right now we are going orange and red. Red almost outcomes are bad. If you start doing yellow patients, then I think we will see a better outcome in these cases. And that is true when we are seeing these patients, they are already on medical therapy. They come to us on if they have MR on medical therapy. So only thing changes is they'll continue medical therapy with a decreased dose of the medications. But if we see a success, usually 70-80% have a good improvement. between 20-30%, you never see an improvement. They are probably orange and red patients.
Yeah.
So I think that's where our movement has to be, that start taking these cases early on. Definitely then we will see, patients will benefit better rather than wait on GDMT.
Yeah, early on is one important point. I think the difficult part is convince our primary care doctors and cardiologists because of the other newer class of GDMT. And with MitraClip and TEER, you know that there are three issues with secondary MR. One is it's a ventricular problem or it's an atrial problem. Right? You cannot fix that with just MR alone. We've actually asked our EP colleague, can you fix the AFib? And they're very reluctant because it's a chicken and the egg. Just like ventricular disease, you need to have GDMT, and most patients, and same as in China too, right? You cannot afford the medication, or they don't take the medication. They think, oh, I feel better, I got a procedure. And then the MR comes back, they got heart failure admission not because the procedure failed, but the holistic care of the patient failed. So I think that's what we need to emphasize to our community, that it's not just the procedure, but with secondary MR, you have to treat the whole patient and you have to maintain that. And that's why co-op was successful. Every little change was documented. It doesn't happen in real life.
And that is true. There is a paper actually which I did not include, that once your clip is done, MitraClip, at 9 months, 6 to 9 months at time period, while there is a GDMT, 90+% compliance at the time in 30 days, it becomes less than 50% after 6 to 9 months. That's but life. I mean, I don't know what we can change it, but that's where some of those patients are the one who is going to develop symptoms sooner than otherwise.
And we see that in our office.
And we see it quite a bit. Yeah. All right, Pedro, all yours now.
Very good. Well, thank you very much for the heart team members of the Cath Lab for this super exciting case. Thank you also for our co-moderators in China, Dr. Mao and Dr. Yang. And most importantly, thank you guys all for joining us for this exciting case. Most importantly, this afternoon, this case will be already available at ccclifecases.org. And last but not least, our structural life cases occur in the second Monday of every other month. So our next one will be December, I'm sorry, I apologize, second Tuesday
December 7th,
of
right?
every other month. And our next one will be December 12th at 9 a.m. Thank you so much.
Bye-bye.